Welcome to the Deep Dive. Today we're taking a shortcut deep into the world of diagnostic medical imaging. We're focusing on a finding that is really subtle, structurally disruptive, and just notoriously difficult to spot. We aren't talking about the classic massive tumor that screams for attention. This is something far more insidious.
Exactly. We are diving into what's called architectural distortion, or just AD for short. And this is a finding that, it challenges everyone, radiologists, surgeons, because it's not a definite mass. It's a disruption of the tissue's fundamental pattern.
A missed mammographic lesion, I think, is the term I see.
Hallmarks watch and call, which is why specialists absolutely have to train their eye to see it. And the stakes are high. 4% of all breast cancers, so a really significant portion, first show up only as AD.
Okay, so let's unpack this. Our mission today is to define AD, using the official language, the BI-RADS definition, and then trace how different imaging technologies from mammography to MRI actually find it.
And most importantly, we have to distinguish the benign mimics, like harmless scars, from the truly malignant suspects.
Right, so you know what kind of systematic and frankly aggressive management approach is required.
It really is a high-wire act in diagnosis. You're turning this image of subtle tissue pulling into a definitive diagnosis, and there's almost no room for error.
Okay, so let's ground ourselves in the official lexicon. For anyone following the BI-RADS 5th edition, what is the precise formal definition of architectural distortion?
The definition is actually very crisp and really essential. It's distortion of the breast parenchyma with no definite mass visible.
No definite mass visible, so the focus is entirely on the structure.
Yes, the architecture of the breast tissue itself, how it's being pulled or rearranged. It's not about the shape of a lump. It's about what's happening to the tissue around it.
So if we translate that into what someone's actually seeing, what are the key characteristics? What's the telltale sign?
You're looking for a few specific visual hallmarks. The most recognized are these thin, straight lines or spiculations that radiate out from a central point. It's like the spokes of a wheel, but without a visible hub.
I see.
You might also just see what we call focal retraction, where the tissue seems pulled back, or an unusual straightening, especially at the edges of the glandular tissue. Of course, AD can also show up with other suspicious things like asymmetry or calcifications, but that disruption, that pulling, that's the key identifier.
That stellate or star-like pattern is what makes it look so suspicious for cancer. Right?
Yeah.
It suggests something is actively pulling the healthy tissue inward.
Precisely. But, and this is a huge but, there's a critical exception, and it's what makes this so challenging. The single most common cause of architectural distortion is something completely benign.
Which is?
A post-surgical scar.
Okay, so how does it work clinically? If a patient has a known history of surgery, how does that change the whole assessment?
Well, if the patient has a confirmed history of surgery or, trauma in that exact spot, and we can see the finding is stable over time, then we can typically call it a benign BI-RADS 2. It's just scar tissue doing what scar tissue does, pulling on its environment. But if there's no surgical history, or if that distortion is new or changing, then AD immediately defaults to highly suspicious. It absolutely requires a tissue diagnosis, because it could be malignancy, or it could be a critical benign mimic called a radial scar.
So without a verifiable injury, that distortion is treated as suspicious until proven otherwise. That sounds like a very clear, uncompromising rule.
And it has to be. That aggressive posture is necessary because AD is a surprisingly frequent finding. It accounts for about 6% of all abnormalities we find during screening mammography.
And technology just completely shifted how often we even see it. Let's talk about digital breast tomosynthesis, or DBT. How did that change the game compared to the older 2D mammography?
Oh, DBT completely changed the game. Remember, 2D mammography is just a single, flat image. Subtle AD can be so easily hidden by normal, overlapping glandular tissue.
Right, it's all compressed.
Exactly. But DBT creates these multiplanar images, essentially slicing through the breast tissue. By getting rid of that overlap, it makes the subtle pulling of AD far more visible and much easier to localize for a biopsy. We saw the incidence of AD detection pretty much double with the widespread adoption of DBT.
Wow. That sounds like a huge win for early detection. We're finding twice as many of these structural changes. But I did notice in the source material that this comes with a bit of a statistical trade-off.
Yeah.
Something about the positive predictive value.
That is a crucial nuance, and let's pause on that. Positive predictive value, or PPV. For anyone who might not track these numbers daily, PPV basically tells us, of all the findings we send to biopsy, what percentage actually turn out to be cancer?
The likelihood that what you're seeing is actually malignant.
Exactly. And with 2D mammography, when we saw AD, the PPV was historically very high. With DBT, the overall detection rate surged, but the PPV for malignancy drops slightly. It's reported somewhere between, say, 43 and 50.7%.
Wait, if nearly half of the AD found by DBT is still malignant, that is incredibly high. But the fact that the PPV dropped, that must mean DBT is also catching a lot more subtle changes that turn out to be benign.
Precisely. We're detecting more true AD, but we're also picking up more benign structural changes, like subtle scarring that used to be hidden. It's a challenging balance, but the takeaway is still this. Confirmed isolated AD is highly suspicious and must be biopsied. The benefit of catching more cancers earlier is worth the slightly higher rate of benign biopsies.
So if mammography gives us that first alert, how does ultrasound help characterize this? It's a structural thing, not necessarily a mass.
That's a great question. On sonography, we look for the effects of the distortion on the tissue around it rather than the mass itself. So we look for local tissue compression, the obliteration of normal tissue planes, the straightening or thickening of those fine connective tissues, the Cooper ligaments, or just disruptions in the normal ductal patterns.
I see. So the ultrasound is detecting the mechanical consequence of the pulling. If you confirm AD on a mammogram and then you find a correlate on the ultrasound, does that raise the suspicion level?
Oh, it absolutely raises the red flag. If AD has an associated sonographic finding, especially something like an irregular mass or highly angular margins, that finding has a significantly higher likelihood of malignancy. It's tangible evidence that something is aggressively interacting with the anatomy.
And finally, what about MRI? I would imagine for a high-risk patient with dense breasts, MRI might be the perfect tool here.
MRI does have a role, for sure,
Yeah.
especially in dense breasts where mammography can be indeterminate. On MRI, AD can show up as a non-enhancing finding like focal retraction or as an associated feature near a mass. But, and this is a critical limitation, MRI does not effectively differentiate between a benign radial scar and the malignancy.
So it can see it, but it can't tell you what it is.
Right. It helps identify the presence of the distortion, but it often can't determine its pathological nature, which means you still need a biopsy.
Okay, we've established AD is suspicious unless there's a clear surgical history. Let's get into the why, the mechanism. Why do malignant lesions, in particular, cause this specific star-like pattern?
This is where we connect the image to the biology. Malignant lesions kick off what's called a desmoplastic response. Essentially, when cancer cells take hold, the body's microenvironment tries to wall them off. It's a violent, aggressive, and ultimately ineffective attempt to stop the invasion. And this causes a massive proliferation of dense, fibrous tissue right around the tumor.
So this fibrosis is the body's attempt to contain the threat.
Exactly. And it's that dense fibrosis that pulls on the adjacent normal breast tissue, creating that characteristic pulled, spiculated, star-like appearance on the images. It's less about the size of the lesion and more about the strong, reactive retraction of the tissue around it.
That provides fantastic context for why it looks so aggressive. Now let's talk about the benign causes, the mimics. We already covered the post-surgical scar. What's the next most crucial mimic?
That would have to be the radial scar. It's also known as a complex sclerosing lesion, or CSL, and they look terrifyingly similar to cancer on a mammogram. Sometimes they're called black stars because of their highly spiculated appearance. A CSL is just the term for a radial scar that's a bit larger, usually over 1 centimeter.
I noticed in the sources that even when AD is confirmed as a benign radial scar after a biopsy, surgical excision is still often recommended. Why would a benign finding still need surgery?
This is a major clinical hurdle. Sampling error. Radial scars can have little areas of atypia hidden inside them, or they can hide an adjacent malignancy, like DCIS. Because a core needle biopsy only takes tiny samples, there's a serious concern about undersampling the area.
So you might have missed the bad spot.
You might have missed it. To eliminate that risk, surgical excision is frequently required to get a complete look at the entire lesion.
Are there other, less common, benign things that can cause AD?
Certainly. There's fibromatosis, which is uncommon and sometimes associated with breast implants. We also have the granular cell tumor, which usually presents as a firm, irregular mass. And finally, sclerosing adenosis, which involves enlarged duct lobular units with fibrosis. This one can create distortion, and confusingly, it can often coexist with a malignancy.
Okay, now for the threats, the cancers we're most worried about. Which 3 primary types of malignancy are most notorious for presenting as pure architectural distortion?
The main ones are invasive ductal carcinoma, or IDC, invasive lobular carcinoma, ILC, and ductal carcinoma in situ, DCIS.
Let's start with IDC, the most common type.
Right. IDC is very frequently associated with spiculations that radiate from a central mass. It's, the third most common imaging finding of malignancy. The desmoplastic response is classic and usually pretty obvious.
And then there's ILC, which is famously subtle and often presents as the purest form of AD. Why is that?
Well, it's because of the biology of invasive lobular carcinoma, which is about 10% of all breast cancers. ILC cells tend to grow in these single-file patterns. They infiltrate the tissue rather than clumping into a solid mass. This infiltrating growth is incredibly effective at kicking off that aggressive desmoplastic response, causing intense distortion without forming a clear border.
So that's why you get the pure AD so often with ILC.
That's the direct link. The microscopic pathology creates the imaging finding we see.
And finally, what about DCIS?
Up to 10% of ductal carcinoma in situ, or DCIS, can present as pure AD. While we often think of DCIS with suspicious microcalcifications, the distortion itself comes from interstitial sclerosis, basically a hardening around the abnormal cells, which can involve the Cooper ligaments and cause that architectural change.
So we've established AD is an immediate red flag unless it's a known stable scar. Walk us through the systematic steps medical professionals have to follow to manage this.
Okay. The systematic approach always begins with history. You have to evaluate the patient for any previous surgery, biopsy, or trauma. Then we use multimodality imaging strategically. We start with mammography, move to DBT for better localization, and then use ultrasound to look for a physical correlate.
And things like MRI or contrast-enhanced mammography.
Those are usually reserved for cases that are still truly indeterminate, especially when you're dealing with very dense breasts.
And the goal of all this imaging is to characterize the finding, right? Is it standalone, or is it associated with other suspicious features?
Exactly. We're on the lookout for those really suspicious features. High-density distortions, clustered microcalcifications, angular margins on ultrasound, things like that. These factors all inform the initial suspicion level and the BI-RADS category we assign.
And based on everything we've discussed, the core takeaway is that imaging alone is never, ever enough to rule out malignancy, correct?
Absolutely not. Imaging cannot definitively tell the difference between a benign radial scar and a malignancy. Core needle biopsy, guided by either stereotaxis or ultrasound, is required to get a definitive tissue diagnosis. The consequence of missing a cancer presenting as AD is just too high.
This brings us to a critical management rule that really needs to be emphasized. I saw in the source material just how dangerous it is to downgrade or delay treatment for this finding.
Yes. Following AD as a BI-RADS Category 3, which means a short interval follow-up, is widely considered unacceptable clinical practice. It just shouldn't happen.
Because the malignancy rate is so high.
It's near 20% for AD that's detected by DBT. That's 1 in 5. That high, a positive predictive value mandates an aggressive approach. Suspicious findings get a BI-RADS 4 or 5 and a prompt biopsy. Delaying a diagnosis when AD is present is a major clinical pitfall.
So what happens if the imaging looks really suspicious, a definite BI-RADS 4, but the core needle biopsy comes back benign, maybe as a radial scar?
That's the crucial issue of radiology-pathology concordance. If your imaging is highly suspicious but the pathology comes back benign, you have a discordance. You cannot trust that result. Further evaluation is mandatory. That usually means a repeat, more targeted biopsy or, more often, surgical excision. The concern is always that the first biopsy missed the small focus of cancer.
So a false negative.
A false negative from sampling error. It's a huge pitfall.
Besides that, what are the other common diagnostic challenges that make spotting and characterizing AD so difficult?
Well, breast density is a major one. Dense tissue can act like camouflage, obscuring the subtle signs of AD even with DBT. Another common trap is when the AD is only visible in one imaging view, say the CC view, but not the MLO. That requires the specialist to get additional targeted views to really evaluate it properly. Otherwise, you could dramatically underestimate its significance.
Architectural distortion really is the ultimate subtle clue in breast imaging. It signals a fundamental disruption that demands expertise and, critically, a very aggressive management approach. And as we discussed, detection rates have just jumped dramatically because of technology like DBT.
The rate of change has been remarkable. We are now seeing things that were completely hidden before, forcing the field to confront these structural changes much, much earlier.
So here's our final provocative thought for you to consider. As imaging technology keeps improving, getting more and more detailed, we're going to detect even more of these subtle disruptions. And we know that even benign mimics like radial scars can carry an inherent risk of atypia. So, how will the standard definitions for what's benign versus what's suspicious continue to shift? Will this high detection rate of AD and radial scars ultimately push the medical community toward recommending surgery for a wider array of findings that we once just watched?
The standard of care is a moving target,
Mm.
It's always chasing the capabilities of the machine. It forces us to ask, what's the risk threshold of living with a structural disruption that we now know is there?
Thank you for joining us for this deep dive into the nuances of architectural distortion. We hope this knowledge provides some crucial context for managing this really challenging and critical area of breast imaging.